Good evening, everyone. This is Dr. Meera from the Part 3 Summit Group, and we are here to discuss about the early pregnancy module. Here in this session, we will be looking at the key points of what it takes to cover the early pregnancy module, and then we will go to a station, an important station to cover. It will be with Dr. Shruti, who has agreed to volunteer for the station. So without wasting much time, we will go right away. So early pregnancy module is a short and sweet module. This is one module which you would need to be doing at the beginning when you are preparing for part 3 examination. It's easy to cover, and as you would have already seen in the part 2 MRCOG examination, the guidelines and the related talks are very small and very easy to cover. The same way, the number of tasks associated with this early pregnancy module is very less number of tasks when compared to a larger station and modules like maternal medicine and urogynecology, something like that. So this is easy to cover, and at the same time, to start with, if you finish this module, it's like some chunk of it you had covered, and this is important to practice in terms of the major domains in which you will be assessed in an SPT. If it comes to SPT, you will be assessed on the communication aspect with the patient and the patient safety. Though it is a small module, a lot of things, small tidbits are there throughout the station, which you need to cover sometimes with overwhelming attitude and anxiety associated with the exam. The candidates might forget certain important key points. So these are the two very important domains you should not overlook. And when it comes to SD, how you communicate with a colleague is going to matter, right? The tasks which you would need to prepare would be, these are the main topics. When it comes to ectopic pregnancy, you will see a structured discussion, and also it could be a SPT where the patient is coming to you following a surgery, or she is coming to you following diagnosis of an ectopic, or you would be the one opening the diagnosis of the ectopic and the further management aspects, or it could be an emergency station as well. Could be miscarriage, the same way it could be a BBN station, or you would be discussing about the further management aspects. Pregnancy of unknown viability, you don't know whether this is going to be a miscarriage or this is going to be a live pregnancy. Sometimes it will be diagnosed as a miscarriage, but then you would need to be following up. That could be the pregnancy of unknown viability. Mostly this will be an SPT. PUL, again, SPT. You would need to explain clearly to the role player what it is at all. So what are the possibilities from this point of time? The patient can go in for whether it could be a very early pregnancy, or it could be an ectopic, and also it could be failing pregnancy also. So how you should be following up, what are the red flags you should be telling the patient, and some other patient concern could also be added as well. The patient might not want to carry on forward with this pregnancy, where you would be nudging whether to wait at all, or you would need to, terminate, give an abortion option at this point of time, even if this is a PUL, right? So it could be that kind of station as well. And hyperemesis gravidarum, there is a famous Lisa book station where there is a background of molar pregnancy with the hyperemesis gravidarum. This is a structured discussion. Since this is also a new GTG, this is one of the key tasks you would need to read about, right? Molar pregnancy again. It could be an SD or SPT as well. You should not be forgetting about the follow-up points and the clarity in which you explain a molar pregnancy to the role player matters. You would need a lot of practice here, and all these stations, how you do communicate to the role player matters. So this is an essential module where you practice with the BBN and the communication aspect of the patient. And RPL, again, it will be emotionally charged station. RPL with Mr. Miscarriage is again an important SPT. It could be an SD as well, because there is a recent GTG based on this. So you would need to be thorough about the clinical knowledge also. And then the role player will come up with certain questions also, which is based on the newer, the updates in the RPL guideline. So these are your tasks which you will be preparing in the early pregnancy module. So the points which you need to cover will be clinical reasoning in the early pregnancy emergencies. You would need to think this is an emergency, and then you would need to do the further steps, right? Like admission, you will be calling on the colleagues and then arranging for the blood and blood products. Sometimes she might be RH negative as well, and you will be setting in the IV, right? So these are all the clinical reasoning and the next steps you would need to tell to the examiner, or you would need to explain to the role player. Ectopic pregnancy diagnosis and management, like we saw, it could be any point from the diagnosis till the management. It could also involve further follow-up also, right? Miscarriage counseling and management option, communication during uncertainty and distress, how you are as a doctor showcasing your empathy skills, right? So this is going to be assessed by the lay examiner, right? So this is another key aspect you would need to practice with the role player. Interpretation of ultrasound and beta HCG trends. So please revise these things. In part 3 MRCOG, you should not be revising a lot of theoretical aspects, but still make sure you revise how you would be assessing the beta HCG trends and what are your next steps going to be, whether she is a candidate for medical management. Suppose if this is an ectopic pregnancy, so is she a candidate for medical management, and how the trend is, how further, when you will be asking her to repeat the beta HCG. Suppose if she did salpingectomy, what is the test she is going to do? Suppose if it is salpingotomy, what is the test that she is going to do? So that make sure you revise, right? Prioritizing patient safety and escalation. Most of the early pregnancy initial steps ST5 should be able to do, but still you would be needing to escalate when there is an emergency, and you will be involving the colleagues also, thereby demonstrating your safety aspect. Shared decision making and consent. So this is also important because some patients might be asking for a medical management. She might not want a surgery, and she might be thinking of further future fertility aspect also, right? So this needs to be negotiated to the patient, and shared decision making needs emphasis here. Management of complications after treatment. Following the treatment, suppose a missed miscarriage, suppose a suction evacuation is being done and she had a perforation, you would need to tell her about the possibility in the initial aspect, and once the perforation has happened, you will need to tell her the bad news and what were the complications and how she needs to be followed up, what are the future aspects of fertility which might be impacted. So that communication aspect is important to be practiced in this module. Breaking bad news with empathy. So last class we discussed about the spikes protocol, how you would need to be telling a bad news to the role player. Initially, you will be setting the stage. You will need to give an initial warning shot, see if the support is available. And once you have given the warning shot, you need to immediately go on with the explanation of what is the bad news in a very precise and very clear manner without using any jargons. So once this breaking the initial signposting is done that there is something wrong, okay, if from this point onwards, you should not prolong the time interval between the actual bad news and that initial warning shot. This is going to increase her anxiety. This is going to make the role player angry or more anxious. So avoid prolonging this. Okay, so what we see is not what we expected. I'm sorry to say that this pregnancy has unfortunately miscarried. Right? So once the warning shot is given, give a silent pause and then immediately tell the the bad news. Don't wait, or don't prolong it, or don't increase the anxiety for the role player. Applying NICE and RCOG guidelines in real-time scenarios. So this is how your applied knowledge is going to be assessed. So this is how you would need to concentrate on the early pregnancy module. So practice and hone your skills on the breaking bad news aspects. Please practice with a role player, whoever is your study buddy. You can practice with them, or you can practice with any of us mentors, right? So that you will get a real time experience. The way in which, if you practice by yourself, the problem is you will be very much tired by doing the role of the doctor and that of a patient. So the real time experience of it will be reduced when you do this way by self practice. So please use a role player or anybody in your surrounding. It could be a friend, family member, or your colleague who can act as a the patient. So practice this way and get back with them. How do you feel? How did you feel when I told you the bad news? Could it be better in any way? So get that feedback also and incorporate it in your discussion. And read a lot of patient information leaflets from the RCOG source, from the NHS source, UK source, for you to use. Okay, so that this sounds more appropriate. And practice your skills on negotiating how best to go forward in the situation. I know this is difficult, but we need to go on with the further management steps. So we have certain options available out there. These are the options. So what do you think is the best for you? I'm afraid this option is not the best one for you because of this reason essentially, which is why this option might be proper for you. What are your thoughts on that? Would you need to discuss it with anybody else? Would you need further information on this? So this way, make them choose the best option and go forward. Structured approach in an ST. Most often, candidates who pass do well on structured discussions. All right. So please practice on the structured discussion. Structured discussion is not essentially the same thing as SPT. Whatever you are going to ask to the role player, you will not be saying the same things to the examiner. You are going to discuss the way in which you think to the examiner, right? Why you are asking this question, why you are going forward with the next steps. That logical reasoning needs to be shared with the examiner to score better, right? So this is our recap. Right now, we will be going ahead with the structured discussion. So this is the structured discussion. Dr. Shruti, are you with me? Okay, dear. Your time is up. So your first question, how would you interpret these findings and what would be your immediate next steps? You can answer there.
So, yeah. I can see that in front of me, I have a case of early pregnancy bleeding. Her background is that she's 28 years and she had her pregnancy test 6 weeks back, which came positive, and suction curettage was done 4 weeks back for a presumed miscarriage. Now she's presenting with pain and bleeding. On assessment, I would like to see her vitals, check her abdomen, and see her for any vaginal, any bleeding clots. For her management, I would like to take a proper detailed history and do an examination, send relevant investigations, and then manage further on. Right now, what I interpret from this is that it was maybe incorrectly diagnosed as intrauterine pregnancy because only the decidual tissue was found and no chorionic villi was seen. So it could have been that it was either a ectopic pregnancy. And so my immediate next steps are history examination and investigations.
Okay. Could you tell me what investigation exactly you would want to do?
So I would like to do a beta HCG to see the values and a TVS to see for the location of the pregnancy. And because for further management, I might also need a complete blood picture. I might need her urea electrolytes or LFTs, blood group.
Okay. So this is the further information. The patient reports continuous intermittent right iliac fossa pain, persistent light PV bleeding, no syncopal symptoms. Her observations are as follows. Examination shows, again, tenderness is elicited, no guarding or rebound tenderness is seen. At TVS, you see a heterogeneous endometrium measuring 18 mm, right adnexal mass measuring 3.5 centimeter with peripheral vascularity. Minimal free fluid is seen in the pouch of Douglas. No intrauterine gestational sac is visualized. Now, your question is, what are your differential diagnosis at this point? What are your next steps?
Okay, beta HCG has not been done.
This is the information given to you at this point, dear.
Okay. So my differential diagnosis at this is it could be a very early pregnancy where the pregnancy is too small to be diagnosed. It could also be an ectopic because a right adnexal mass is being shown of 3.5 centimeters. However, it does say that there is the findings which favor ectopic pregnancy is that there is mild right adnexal tenderness, and also there is no intrauterine gestational sac, and there's a right adnexal mass of 3.5 centimeters. And so it most likely the diagnosis goes towards the ectopic. However, I would like to get a beta HCG done, and
Your next steps?
So my next steps will be that I will talk to the patient. I will take a complete history and do a beta HCG and then go on with the management. And because of her pain and bleeding, I would like to offer her immediately some painkillers, offer her admission if give her painkillers and involve my consultant as well.
Okay. So further information, your HCG has come out to be 1200. The patient is hemodynamically stable for now, but now reports increasing abdominal pain during the observation in the unit. A repeat observations shows BP is come out to be 90/68, pulse is 104. Discuss your management options and the factors influencing your choice of management in this patient.
Okay. So for my management options, now it has been diagnosed that most likely it is a ectopic pregnancy, and her vitals are also getting unstable. So immediately we would like to admit her, open an IV line, and send her investigations like LFT, blood group, keep arrange blood also, and see for her and so I would like to discuss with her management options for ectopic, because she already has pain, and there was and she's there's increasing pain. The only option she has available for ectopic is a surgery, and it can be a salpingostomy and a salpingectomy. For that, I will need to know more about her history, about whether her previous pregnancy, how was it, and whether she has any surgeries on her pelvis or down below, or any tubal damage. So accordingly, I will offer her either a salpingostomy or a salpingectomy. Salpingostomy is done when the contralateral tube is unhealthy, and salpingectomy is done when the contralateral tube is healthy. Yeah. Okay. And are there any more questions, or?
That's it, dear. This is your last question.
Okay, so when I do see this patient, initially I'll be taking a proper detailed history, and I would like to know more about her pain, bleeding, since when it happened, what is the onset, for what duration, did she take any treatment at home, for how long it has been, about her bleeding, more if there was any spotting, if there was excessive bleeding, did she have to use cloths, did she have to use any pads, and about any fainting or dizziness episodes that she had, any passage of clots or masses, and in her previous obstetric history, whether she's had any pregnancies before, any previous ectopics, because ectopic can reoccur, and Then I would like to take more about her menstrual history, whether she has regular periods, any contraception that she used, because intrauterine devices can cause there's an increased risk for ectopic. Also, if she had any sexually transmitted infections in the past, which can again be a risk factor for her ectopic. And if she had treated, there was a treatment of cure, whether her partners were tested. I would like to know if any medical conditions that she has, any risk of clots, any increased blood pressure, any hypertension, diabetes, any family history of thromboembolism, any allergies that she has. I would like to rule that out. I would like to know if of course, her blood group, and then I want to know about her support, because surgery is needed, so support will be necessary pre-operatively and post-operatively. Uh, Coming to the management, when I prepare her pre-operatively, I will do a proper I will check for the WHO surgical safety checklist. I will take her consent. I will explain to her about the surgery, salpingostomy and salpingectomy, see what she prefers, and tell her about the risks that salpingostomy has. There could be chances, the advantage is that the tube is conserved, but however there is a risk that there is future ectopic chances in the same tube, and you can there will be chances that she if the pregnancy test is positive later on, she may need further medical or surgical management. And for salpingectomy, it is a better option, because if it is her first pregnancy, she has the contralateral healthy tube for her pregnancy, and there is no recurrence for ectopic in that same tube. However, there are the risks of surgery and anesthesia, like pain, infection, bleeding, or damage to internal organs. There's risk of clots, but however, that will be taken care of, and an expert surgeon will be doing this. For the whole thing, there'll be the multidisciplinary team will be involved. That will include the consultant, the hematologist, the OT team, the OT staff, anesthetist, and once it is done, we will like to send the once the
Yes,
operation
dear.
is done.
It's your time. Your time is up, dear. Do you like to add something more?
Yeah. So basically, post-operatively, we will see her vitals charting, input, output, antibiotic, analgesics, and um, documentation. We'll debrief the patient and her relatives if needed. Mm.
All
And
right.
then we can give her,
Yeah.
patient
Well done, dear.
information. Okay.
Well done. Well done. Well done. Yes, you were a little bit hesitant to start with, but in the last question, I think you went right into the format of a structured discussion, right? What is your take on your own, the task?
So I know I need to complete the history in that format, but because I think the first question was, what do you think of this case? So I don't know, when should I go in detail? When should I jump into the history? When should I go as a detail? Because like the first question was just in the what we usually practice is like summarize your case. Now
Yeah,
what?
yeah, yeah. That's what usually,
Yeah,
you don't go
yeah.
with the summary at all unless it is asked. All right. If
Hmm.
the question is something else, you would need to go with the question only. Be very precise to the question. What exactly is needed for that particular question? So if something like this is being asked, like for example, how would you interpret these findings and what would be your immediate next step? For your immediate next steps, you would need information, right? So at that point also you can mention about the history taking, what relevant history you will ask. All right.
So if it says immediate, like I said, now we'll need to take a proper history, a detailed
Yeah, yeah,
group
of
about
course.
it.
Yes, that would be your
So
next
in that
step.
we just
That will be
so
your
we
next
explain
step.
the whole thing. Mm-hmm.
Not the whole thing, like don't say this whole information gathering step that you will ask. Like, what are the relevant points for a focused history taking? For a patient with positive pregnancy test 6 weeks ago, and she had a suction curettage also, and now she has a little bit of bleeding, and she has abdominal pain, right? So you would need to ask about further details about what exactly happened and how the pain is, right? What kind of bleeding she has, what were the previous scan findings, Okay, so that kind of
Mm-hmm.
information gathering you need to ask, and also to manage her, you need a little bit of background history, right? Like medical, surgical, allergy, the BMI. So this is essential for the management. And right now, she doesn't seem to be in in a shock or emergency. So you need to
Mm-hmm.
ascertain her clinical findings also, examine in the presence of chaperone with her consent. I'd be looking at her vitals, I'd see her pulse, blood pressure. So that way you'd need to answer. So imagine and don't always go into a format of how you practiced. Sometimes that might not be the question at all. So be precise to the question. Answer to the question
Mm-hmm.
only. Do not summarize unless asked. Okay.
Okay. Okay. So SD will not always begin with the summarization.
Yes, definitely not. What will be your next steps can be a very typical SD question. They will not
Mm-hmm.
ask you to summarize always. And unless asked, do not summarize. That is going to cost you the time.
Okay. Okay.
All right. So because of this, you were off put, right? But then for the
Mm-hmm.
further questions, you were able to answer. The last question, especially, you gathered yourselves and you were able to answer a lot of things you missed in the first answer.
Mm-hmm.
So, I think in 5 minutes or so, the meeting will end. You please join back with the previous link. So, right now, we will just go on with your feedback and then we will discuss the key.
Mm-hmm.
Okay.
Okay.
Anybody else has any take on this? Any further input for the feedback? Dear participants, any of you could add any more points before I
Can
give a
we
detailed
ask
feedback?
the examiner, like how I ask, can I ask the examiner if there are further questions?
Yes, of course, you can ask.
Mm-hmm.
Definitely, you can ask. And you can also, if you have enough time left at the end, you can also get back to the previous question. To the first question, I would like to add, could you repeat this question? So, this is something you could always ask. If you don't understand the question, could you please repeat it? That can definitely be asked. Okay. You'll not be downscored for that. It's a polite way of just asking whatever is in your mind at that point of time. And if you have enough time left at the end, you can also get back to the previous questions and add to the questions points which you think you missed. Okay.
Okay. And in this, we will not do incident reporting
No need to be reporting as such. It's not as such a miss. All right. We don't know what exactly has
because
happened before.
because she was done suction evacuation for a presumed miscarriage. So I didn't know, but it was not done in our
It's not
hospital. So I don't.
mandatory. It's not mandatory here to report this as such. But if you think she is asking why this happened, was something missed, we are not sure at this point. We will look into it. That could be a very neutral way of saying things. Although it could be a
Mhm.
pregnancy of unknown location also previously, and she would have come with a lot of bleeding and clots would have been there, and for that purpose, she would have done. They would have proceeded with the suction evacuation. Right? It's not wrong to
Mhm.
mention an incident report, but then it is not mandatory here.
Mhm.
Yeah. So let us go with the detailed feedback. So initially, you were hesitant because you were off put by the initial question, first question, I think. But you gathered yourself well and you read out the pain and related symptoms, and you rightly diagnosed this as a possibility of ectopic pregnancy. You also gave the right differentials, like very early pregnancy or the pregnancy where if the whole products of conception has been expelled, this could be a complete miscarriage as well. So the possibilities, differentials you gave rightly. But then, when a question is being asked, you could always be silent instead of reading out what exactly is given already. Okay, so instead of persistent, she has pain and she has ongoing bleeding, and right now there is no residual tissue in the HPE. So instead of that, you can just be silent and think and surmise your answer. I think this is a possible. There is a possibility this could be an ectopic pregnancy because there is no decidual tissue, there is no villi, and there is only decidual tissue. So this way you would sound more organized. So you can pause also. You need not be filling the whole station with your voice. You can pause, think, and also answer. And relevant investigations, you mentioned what are your further steps? When I asked, you mentioned relevant investigations will be done. You would need to be very clear onto the investigations. So the next steps also include information gathering, clinical examination with the consent in presence of chaperone, and the investigations. So always detail each step. Usually the candidates miss on the information gathering. You need to ask from the history. You need to tell the examiner from the history point of view whenever situation is given. Usually the history is usually missed, so make sure you start from there. And the possibility, what it could be. You mentioned incorrectly diagnosed as a miscarriage, right? This it could be, downgrading your colleague. This could be a missed missed diagnosis of miscarriage, could be a better way of putting, not blaming the colleague. So incorrect diagnosis is blatantly saying that the colleague is wrong, had been wrong, and they made the patient end up in this kind of complication. So instead of that, you could as well say that this could have been a miscarriage which had been missed. That could be a better way. And the differentials you gave rightly. And you for the next steps, I think I gave you a prompt. What are your next steps? Because at that point, initially you were hesitant with the scan, your HCG, and you mentioned the DD and relevant investigations. With that, you stopped, I think, and you needed that prompt. So make sure you again look at the question, or you can ask the question again. All right. So, and the time taken for the first question was also appropriate, no issues there. And for a patient who had this finding, what is your first thing? When you rightly mentioned about the ectopic pregnancy, for an ectopic pregnancy diagnosis, what is the investigation needed? More than the HCG, it should be the ultrasound. So ultrasound is going to tell you that where the pregnancy sac is, right? So if the pregnancy sac is not visible, that is when you go back to the HCG. Or when the pregnancy sac is visible outside, you will need to do the HCG to make sure how your management steps further will be, right? So that is how your line of thought should be. Okay.
But in
Get my
this,
point?
there is no mention of extrauterine sac.
So you can see right at Excel mass. It's not a cyst. It's a mass measuring 3.5 centimeters with peripheral vascularity. This is a ring of fire appearance. This is classically the description of the ectopic pregnancy. So if there isn't right adnexal cyst, okay, if that is the case, then you can be thinking that it could be a corpus luteal cyst. But a mass is suggestive of your ectopic pregnancy. Do you get me? Would you agree that? Yeah.
Yes, yes,
Yeah,
yes.
so that is why you would need to go for the USG first, and then with the USG report for further management, you will be asking for the HCG. That is why I did not tell the HCG. So the differential diagnosis was given again rightly, and the next step. So the second question went on well. You offered a very good DD, and you again, following the information that HCG is not given, again you insisted on the HCG. That was well done. And for the third question, the final question, where you were able to surmise the whole thing and you were able to give holistic management involving the colleagues also. And in retrospect, you looked at the information gathering points which you needed to ask, like the medical surgical details, allergy details, even the VTE risk you mentioned family history of VTE. Usually this point is missed. This is one other key point which should be mentioned in the early pregnancy station, because risk assessment for the venous thromboembolism needs to be done in the early pregnancy as well. Whenever you are admitting the patient or she is coming in for a visit, or you have any further management in plan, this needs to be assessed throughout, right? So this is one thing which usually is missed. You mentioned that though this was not assessed as such, you mentioned that point. That was well done. And admission, IV line, and patient discussion, what is happening, those are the points which you portrayed very well. And this is the time in which the history came in, right? The initial history, which should have been answered in the first question, came into this answer. But the thing is, sometimes in SD, if that particular question was not answered, the examiner will not take the answer for the other questions. Like if you answer the first question's answer in the third question, you will not be marked. So make sure you mention that specifically wherever needed, right? And following the patient discussion, you mentioned the MDT involving the blood bank, anesthetist, the consultant, all those things. And for follow-up also, please mention GP. Okay, for following the discharge. So mention the GP also in the care, and specialist nurse also in the care, not just the doctor team. All right. And surgery, you mentioned about the salpingectomy, salpingotomy, so that was all right. But the route of surgery needs to be mentioned, because if she is in a hemodynamic collapse, she would need a laparotomy. So the feasibility of laparoscopy will be decided in consultation with the anesthetic team at that point, right? So the route of surgery is important to be mentioned. You mentioned the WHO safety checklist, that was well done. And once inside the surgery, what are the options? The salpingectomy, salpingotomy, based on the previous details and any fertility reducing factors that you see intraoperatively. That point also you mentioned. And make sure you mention the follow-up aspect also. After debrief, I think you mentioned debrief, and then if salpingectomy is done, what is the follow-up? If salpingotomy is done, what is the follow-up? All right. And the advice following the major deal here, the post-operative advice, the contraception, and the next pregnancy advice. There is a possibility of recurrence, right? So make sure she goes into the early pregnancy unit. If she becomes pregnant later on, till that point of time, make sure you just mention it there. So most of the points you were able to mention. So I think you would get a pass in all the domains, right? Well done, dear. Any more points anybody would like to add before we go on to the key discussion? Dr. Sumi, do you like to add something? Are you with us?
Yes, Dr. Meera, I've been listening. Yeah. So nothing much to add as well. All of the points you have, elaborately discussed. So we shall go forward with the key.
Okay. So let us go into it. First, there is a patient, a 28-year-old woman presents with persistent lower abdomen pain and ongoing vaginal bleeding. She had a positive pregnancy test 6 weeks ago and was managed elsewhere for presumed miscarriage with suction curettage. Histology from the evacuation shows decidual tissues only and no chorionic villi was identified. How would you interpret these findings, and what would be your immediate next steps is the question. So go right away into the interpretation. So that is your question. The interpretation is concerning because we don't see any chorionic villi. So there is no intrauterine pregnancy. The persistent symptoms could be due to the ectopic pregnancy, and it could be due to complete miscarriage, which is resolving right now, or it could be a retained products of conception as well. Right. Right. So the histology might have missed any pregnancy product. So it could be retained products of conception as well. So correlation of symptoms and initial imaging is essential. So immediate next steps would be assess the hemodynamic stability. This is one of the most important safety points. Full clinical reassessment, including a focused history taking. So here you should be mentioning how she presented, the details about the previous presentation, what was done, and what was the discussion done, right? And is there any previous scan done before this suction evacuation, all right, and current symptoms and current status. So this is the focused history taking, and include the allergy, medical, surgical details, ask about the BMI, and if there is any reservation for transfusion, because there is a possibility this could be an ectopic pregnancy, right? She might need a transfusion. So ask about the reservation for transfusion. Again, this is a safety point. Review your previous ultrasound findings, like we discussed. It could mean that there is no sac inside or outside visualized previously, right? Arrange for an urgent transvaginal ultrasound, because this is a patient with pain and persistent bleeding. You would need to do an ultrasound as soon as possible. So the blood tests, you mentioned it rightly. Full blood count you will be doing, group and save, urea electrolytes, and senior review and early escalation. So at that point, you would not be calling the senior immediately, but you would need to put in a word that such a patient is here, right? Safety net regarding ectopic rupture symptoms, counsel regarding the current status. You will right away tell the patient that this is concerning. We will be doing these things, essential steps, next steps, which needs to confirm what exactly is happening. So this communication with the patient part also needs to be mentioned in the structured discussion station. I'll be telling to the patient regarding the next steps and detailing and exploring any concerns that she has. This you need to tell the examiner. So the further information which was given to you was she has continuous pain, persistent bleeding, no syncopal symptoms. Her observations are all right. And TVS finding is given at you. So TVS is telling you that there is a heterogeneous endometrium measuring 18 mm. So this rules out retained products of conception, right? And there is a right adnexal mass. So this mass is suggestive of an ectopic pregnancy. This is a probable diagnosis of ectopic pregnancy. If you could, recall the NICE guideline on this, the probable ectopic pregnancy is heterogeneous mass, right, in the adnexa. And this peripheral vascularity is what we classically call as the ring of fire appearance. All right, so the right cystic mass in the adnexa could be corpus luteal cyst, right? But this mass, heterogeneous mass, usually is a ectopic pregnancy. And minimal free fluid in the pouch of Douglas is not a significant finding. We would be going ahead with the the emergency steps if we see a moderate or a large amount of free fluid in the POD. This could say that the ectopic has ruptured, right? So minimal free fluid is not a concern. And there is no intrauterine gestation sac, so that confirms our diagnosis almost. Question 2 now says, what are your next steps at this point? Following your diagnosis that this is an ectopic pregnancy, what are your next steps? So most likely you know that this is an ectopic pregnancy. The other differentials as well could be a chronic ectopic, or it could as well be a heterotropic pregnancy. There is one pregnancy inside the uterus which could have been miscarried, and there is an ectopic outside. Or it could be a resolving miscarriage, but this is not very likely because we see a mass and corpus luteal cyst, and again it is not likely. So the further assessment will be right now how the patient is, repeat examination, assess these risks, the BMI risk, the VT risk, and the management, right? Assess pain, severity, and bleeding. This you mentioned it, Dr. Shruti. You will give her painkillers. I'll assess the pain, severity. Well done on that. Assess the beta HCG to decide on the management options, because you know that this is an ectopic pregnancy and pain is not very much at this point. So based on the HCG results, you can decide on the management steps. Assess the suitability for medical management. Group and save and reserve for transfusion as such. So the interpretation is suspicious of tubal ectopic pregnancy, right? The heterogeneous endometrium could be due to the residual reaction, right? This is not possibly, there is no possibility of retained tissue. This is just the area stellar reaction, which we know about, right? So no evidence of intrauterine pregnancy. The counseling point also you mentioned rightly. Explain the concern for ectopic clearly and sensitively. Explore concerns. Right now, if she has any further questions, you need to address that. Explain the need for treatment and close monitoring, which is why you will admit the patient. So because this patient has a little bit of pain and the scan finding has told that it is an ectopic pregnancy. To discuss the fertility implications and future pregnancy outcomes, provide safety netting advice. Further information is this 1200 is the HCG, but she has an increasing pain and the BP is crashing. So at this point, you know that this is a ruptured ectopic pregnancy. So the management option, you would need to tell essentially why you are opting for a surgical management over a medical or an expected management. This you mentioned there. Medical management is not appropriate because she's not stable and the pain is not minimal. And there is a suspicion of rupture here at this point. So you will go ahead with the surgical options, right? Usually, whenever you mention the surgery, make sure you mention the route of surgery. The route of surgery is usually missed. You will mention the salpingectomy, salpingotomy, but whether laparoscopy is possible for her based on her hemodynamic status, whether it is laparotomy or laparoscopy needs to be mentioned in the station. Okay, so expectant management again is not appropriate. So immediately, what are you going to do? Recognize the likely rupture with hemodynamic stability. So assess the patient at that point. Call for senior help immediately. Anesthetic review on an emergency basis, and based on the ABC assessment, you might need to do this activation of hemorrhage protocol, right? Large IV large bore IV access, you will start fluids, right? Access alone is not sufficient. You need to start the resuscitation, right? You need to mention that. And blood for cross-matching and transfusion after ruling out in reservation for transfusion. And continuously she needs to be monitored, and consent for emergency surgery needs to be mentioned again at that point of time, right? And proceed to urgent operative management. The surgical management will be, again, I repeatedly insisted, whether laparotomy or laparoscopy based on patient stability and the expertise available in the unit. So control the bleeding, and as per the background, you go for salpingectomy or salpingotomy. And further management should be based on the HCG monitoring and whatever surgery was done, right? If it is salpingotomy, you will be doing HCG weekly. If it is salpingectomy, you will do the UPT in 3 weeks' time, right? So discuss histology or MDT if needed. So this is not a routine point, but just follow up with the histology. Histopathological examination needs to be done with the specimen collected. So the follow-up advice, contraception advice, right? Following the surgery, early pregnancy advice for future pregnancies, because there is a risk of recurrence, and she has had an emotional troublesome pregnancy now. So the further support for her mental health also needs to be mentioned. So this is the key for the station. So the domain wise, how you will be scored, whether your clarity in mentioning these things, whether you are clear in mentioning the information gathering steps at each point with the questions, right? So that is the information gathering. Usually these are the points for the SPT, but when you mention the targeted history taking, this information gathering domain will be assessed. All these points you were able to mention. For the last question, you were able to mention all these points. So this was missed, I think. Reservation for transfusion was not mentioned. So again, your interpretation is also part of information gathering. It overlaps with the applied aspect as well, but whether you are interpreting is part of information gathering domain. Okay, so communication with the patient, consent is something important, and the discussion and exploring concerns, right? Mentioning things in a sensitive manner, explaining in a lay language. So all those things are important. And whenever we are discussing a structured discussion with the colleague, make sure you mention the medical terms only. When you were asking for the last question, I think when you were telling the details, the complications, you went on to the SPT mode. Clots, injury to the surrounding organs. So that way you were mentioning in lay terms. Make sure you mention in the medical terms only in a structured discussion station. So communication with colleagues, escalate early to the senior clinician. This was mentioned. The teams were mentioned. Make sure you mention the other colleagues also, like staff nurse, okay, GP follow-up, counselors, right? So all those things also should be kept in mind. Safety points, mostly the missed point is the risk assessment for VTE, and yeah, the surgical safety checklist also you mentioned rightly, that was well done. And the follow-up advice is also part of safety planning. Okay. Applied knowledge, how you are going to apply your NICE guideline for ectopic pregnancy management in an emergency situation, how you are going to explain your preference for surgical aspect in an emergency is how you showcase this applied clinical knowledge. So this is how the station needs to be taken forward. So hope this discussion helped you. Do you have any queries or doubts here?